Paul,
Asif, how are you?
well, and you?
Good, man. It's wonderful to see you.
Lovely to see you.
Oh, thank you.
Is that Michelle there?
It's Michelle.
It is. Hello. Nice to meet everyone.
Are you? Hi, Michelle. Are you from Merck?
I am indeed.
Are you going to say a few words, Michelle?
Very few words, yes. Just
Do you
a
want to
quick
say it
intro.
at the beginning or at the end?
If I could say at the beginning, it would be better. If
Okay.
you don't mind.
I'll introduce Paul, and then Steve will thank Paul. And is it okay, Paul, if we interrupt you as time goes by?
Yeah, sure. Absolutely. No problem at all.
Okay. Is there a bit of time at the end also for some Q&A?
Yeah, should be time, yeah.
FAQ?
Yes, absolutely.
Watch it carefully.
Listen, I'm going to just spend 1 minute just congratulating Steve on the birth of his new child. So, yeah, but born on Monday.
Yeah.
Oh, congratulations.
Yeah, we had a good gynecologist.
Yeah, the 10 best on the 15th. So that I think is quite right. And then Paul, we'll bang on with fertility preservation. Is there anything specific you need or want to say?
No, nothing's really. Yeah, I'm happy to just crack on with my talk, yeah, when you're ready.
Have you checked out your slides? They all come through?
Everything
And
seems fine, yeah. I checked that they share okay and all that at the beginning, so it seems fine, yeah.
Okay, that's wonderful. We were looking forward to it, Paul, and thanks so much for taking out your time.
Thanks for inviting me. It's a pleasure always. Especially with these two chair people, yeah.
Yeah, sure. So I'll ask. I'll start. Steve will finish. I'll ask Michelle then to say a few words at the very beginning. Michelle.
Perfect.
Okay.
Okay.
How much time we've got this, Steve?
Yeah, we're going to start. It's 2 minutes past 5 already. 3 minutes past 5 already.
Past 5?
Yeah, 2 minutes past 5.
Are we on now? Are we on?
I think we should just start, Nadia. I think we can start. And so thanks so much. Pete, you go ahead.
Yeah, thanks very much. Well, ladies and gentlemen, it's a warm welcome to all of us over here from a beautiful Cape Town. It's fantastic to have so many people logged on. It's a tribute to Paul Roux' wonderful popularity and draw as a speaker. He's going to be speaking about fertility preservation, how to ensure a future family. We're very privileged also to have Michelle with us over here, as you can see, Michelle Redlinger-Hayes, and she is the product manager of Merck, and she's going to be saying a few words. Just a look ahead. Next week, we have Dr. Britta Dedekant, and she's going to be speaking about latest screening options for breast disease, and she's sponsored by the Pelvic Floor Foundation. It would be very remiss of me not to say, just before we have Michelle, a great big congratulations to Steve over here, Professor Steve Jeffrey. He's become a proud father recently. And Steve, congratulations.
Thank you very much.
And we wish you very well in the future with your family.
Thank you very much, Pete. Thanks for all you did. Pete was a great gynecologist. I can recommend him. And
a great pleasure, Steve. No, it's always a pleasure to bring your children into the world.
We'll stop now.
Oh, we'll stop now. No. Michelle, would you be happy to say a few words as well?
Thank you. Thanks.
But in general, on to
well, to Steve, a big congratulations. And all I can say is may your coffee be strong over the next couple of weeks.
May your coffee be strong.
Yes, it is. Thanks very much.
But it gives me great pleasure to join this afternoon. Thank you for the kind introduction. And yes, I am the Medical Affairs Manager for Fertility for Merck. in South Africa. And obviously, we have a very firm focus on advancing the field of fertility medicine. And so we are
Sorry,
absolutely
what did you say?
delighted.
Firm.
Firm or sperm
Firm.
family? Huh?
Well, I suppose it can work either way in this case.
Didn't work out well, yeah.
But we are really delighted to be able to partner with the foundation and sponsor today's session. And I think Dr. Roux really needs no introduction, but I would like to say one or two words. He's obviously the CEO of Cape Fertility and a registered specialist of reproductive medicine. His research has been published in leading international journals, and he's presented at numerous local and international congresses. And what's particularly special is that Dr. Roux is currently the elected president of the African Federation of Fertility Societies. And what makes this so special is that this is an organization that's absolutely dedicated to improving fertility care in Africa. And to have Dr. Roux spearheading that organization is just an amazing achievement as well. So I can't think of anyone better for today's talk. And as mentioned, he'll be talking about the topic of fertility preservation and how to ensure a future family. In Steve's case, he has his current family. But for those who are still working towards a family, I think this topic is becoming increasingly relevant in our ever-changing society. So thank you very much for allowing us to partner, and I'll hand back to you.
Thank you very much, Michelle. And Steve, may your coffee be strong. Steve is full of beans, that I can tell you. So Paul, without further waste of time, I'm going to thank Michelle for saying those words of introduction, and a special thank you then to Paul for being with us and taking time out of his valuable schedule. And fertility preservation, how to ensure a future family. Dr. Paul Roux, CEO of Cape Fertility.
Great. Thanks so much. I'm just going to check I can share my slides quickly.
There we go. We can see.
Yeah. Can you guys see okay?
Yep, we can
Yes,
see.
you can see.
Okay, great. So firstly, thank you so much to my two chairs. I've known them both for many years. Pete taught me how to do endoscopy, and Steve and I were friends as registrars for many years. And congratulations, Steve. I'm so happy to hear about your child. And Michelle, thank you so much for such a kind, warm introduction. I really appreciate that so much too, yeah. So let me kick off. And first to say thanks very much to Merck for sponsoring this event. Merck Pharmaceuticals produces a lot of the quality fertility drugs that we use, and they're excellent at always providing, you know, a chain of these drugs to us to keep all our patients going during their fertility treatment. And they're also very dedicated to supporting education around our country and Africa. So thank you so much to Merck for that. So this is where I work in Claremont, opposite the Kingsbury Hospital. And these are my wonderful colleagues. They say you must surround yourself with clever people and makes you look good. So I've tried that strategy here. We've got some wonderful colleagues here. Dr. Suleiman Halen, Joe Potto, Liesel, Oosthuizen, Tamtam Matabisi, and myself are the doctors that work there.
And Paul,
yeah, sure.
which are the clever ones?
All of the ones except me are normally the bright ones. I just look clever, stand next to them, you know.
Okay, good.
And then this is some of our team. We're the ones who could get to go outside for the photo. And but it's important in a fertility clinic because you have laboratory people, nursing staff, admin, it all has to gel together. And that's what makes a good fertility procedure. Here's a few pictures just for fun. A lab person injecting some sperm into an egg, and there's a person getting ready for the egg retrieval in theater, and somebody culturing an embryo in an embryo scope that video records the embryo as it develops. So just before I kick off on the academic side, just to mention, as Michelle said, one of my jobs now is being president of this organization, which is very exciting. It's 18 national fertility societies on the African continent. So 18 countries are signed up members. We started it in 2020, and we've got 21 board members, all senior people from around the continent. And we did webinars in the COVID years, including a Merck AFFS patient awareness campaign. And we also audited fertility training because we weren't even sure how many people were training around the continent. We did our first in-person conference in Tunisia in April this year, We were expecting 200 delegates and 700 arrived, which was pretty impressive. So we were happy the hotel had enough space for everyone. But it was very successful conference, and it just shows that there are so many people on our continent who are hungry for information. And in South Africa, we've got very advanced medical care. So we do have a responsibility to assist other people in Africa who are starting out, and are still behind us. So the people on our board is myself, Jack Biko, and Yusuf Dasu, who represent Southern Africa.
Paul, can I just ask a question?
Yeah, sure.
This is a Pan-African society, isn't it?
Yes, that's correct. Yeah.
Is
So
it Francophone, or in other words, they speak French or English? Because we tried that, and there was such competition between the Francophone and the Anglophones that in the end, we had to give up the endoscopy. But do you have any problems like that, or is it all?
No, we include both, and what we do is a lot of the sessions, what we do, like we're organizing, for example, a conference next year on how to do ovarian stimulation. So we're doing one in French and one in English. So we have to keep thinking about both languages and so on, But yeah, a lot of the French conferences, a lot of them are actually, even in the French countries, are done in English these days. So they still want us to come, even in their French countries. Yeah.
Okay.
So back to infertility again, just to say the World Health Organization says infertility is a disease of the male and female reproductive system. It means you can't conceive after 12 months. And every human being has a right to the enjoyment, of sort of reproductive health. This is also enshrined in our constitution. So it's important that we do pay attention to our patients' fertility. And if you look at the first IVF baby born in 1978, Louise Brown, it's not that long ago, I guess, but now there are more than 8 million babies born worldwide. So IVF has become almost mainstream now in many countries. In our own clinic, we do about 1,000 fresh egg retrievals per year. And interestingly, because we're going to talk about fertility preservation, I just got the stats for the egg freezing as well. So for last year, we did 200 of those egg retrievals were actually for egg freezing. So that's about 20% of our patients that are coming to us for treatment are actually freezing eggs at the moment. We're also doing something called PGT-A, or pre-implantation genetic testing of embryos, which is great because it allows you to understand whether an embryo is genetically normal. And we have, from our stats this year, 55% of all our patients are opting to do the extra genetic testing before putting in the embryos. They don't have to do that. They can just transfer the embryos like in the old IVF system. But knowing the information is important. And obviously, if you've got the information and you know it's a euploid normal embryo, they've got a high chance of working. So again, all the patients over all ages, the pregnancy rate with a single euploid embryo transfer this year in our clinic was 67%, which is excellent. So there is some advantage to PGT. The other thing that we're trying to avoid is too many babies at once. And it's not easy to do this because, especially in Africa, a lot of people still transfer too many embryos. So it's important to say that guidelines have changed and only one embryo should be transferred, especially if the patient's under 38 years old, or if you've tested the embryos and it's normal. So this picture underneath was the famous Octo mom who had 8 children. She actually had 12 embryos transferred and ended up with 8 children born. The interesting thing about her, that was in 2009, it was the first set of surviving octuplets that actually survived. But what's interesting is she actually had 6 children before this. So she ended up with 14 children. And her life...
Paul,
yeah.
Sorry, Paul, that's not the lady from the Pretoria News. That was
no, she's not South African. This is a US lady.
Okay.
And yeah, there was a lot of interest in that case. And obviously there was a bit of medical mismanagement as well. The doctors were struck off the roll subsequently, but anyway. But yeah, we want to avoid multiple births because they cause a lot of problems for the obstetricians. So the first thing, everybody understands that age affects IVF, but the reason that pregnancy rates decrease as you get older is because embryos become aneuploid. Aneuploid just means abnormal numbers of chromosomes. And this is what causes them to fail when you put them in, or to make an early miscarriage as well. Egg donation is one solution. So for patients over 40 particularly, you can get an egg donor to donate their eggs. So it can be useful in women who've got poor quality eggs or premature ovarian failure. And it works very well. But the problem is, obviously, it's a big thing for women not to use their own genetic material. So if there's a way to preserve her fertility or be an auto donor for herself, this is obviously very attractive, and it's what's pushing the egg freezing process a lot. This is just showing if you do egg donation, it doesn't matter the age of the woman. You can see the blue graph at the top. It doesn't matter what age the woman is when you put the egg in. The success depends on the egg, not on the uterus.
Paul,
Yeah.
there's a question here. If you do egg donation, does that deplete your future supply of oocytes or not?
No, it doesn't. So basically in the ovary, you lose about 600 eggs a month. And normally on a natural cycle, only one egg would just mature and ovulate. If you're on the contraceptive pill, even you'll still lose your 600 a month anyway. If you do fertility injections, all you do is mature more of them. So instead of one becoming mature, you might mature 10 or 15 eggs, but you don't change the loss rate of 600 per month. So if you do IVF treatment where you're hyper-ovulating a patient or with an egg donor, you don't decrease their future fertility. Yeah. So the types of fertility preservation, obviously, I'm not going to talk a lot about the male patient in this talk, but just to mention, obviously, we can preserve future fertility, and it's normally quite easy. We can just freeze an ejaculated sample of sperm. You can obviously also extract sperm from the epididymis or the testis and freeze it. The only problem we have is in prepubertal boys, because they don't produce sperm, and there's no technique really for preserving fertility in prepubertal boys at the moment.
Okay.
Some people are trying to take some testicular tissue in the hope that one day maybe they can make those cells, develop into sperm, but there's no actual technique for doing that. And the female patient, we've got different options. We can make embryos like IVF, and that's one advantage of IVF. So if a patient comes to us and they're battling to get pregnant, we get them pregnant, but we have leftover frozen embryos. And these patients, it helps them a lot later. If they get older, they can still have other babies, and the eggs are as competent at the age which they were recovered, if you know what I mean. So IVF is another way of preserving fertility. Egg freezing, you can recover about 85% of the eggs after egg freezing. With IVF, it's even better because embryos, about 95% recover after thawing. But egg freezing has got better over the years, so it's getting closer and closer to the embryo stage. And some clinics quote even more than 90% recovery. But I think this might be a slight difference, but it's not too bad. So egg freezing and embryo freezing is becoming a similar sort of success rate with time. Ovarian tissue freezing can also be done, but it's much more complex because you need laparoscopy and the pregnancy rates. There are cases around the world, but it's not as commonly used.
Now, Paul, just to go back, sorry to interrupt.
No.
What do you do? Now, you were saying that you got all these embryos and they may be used. What do you do if they're not used? What does the law say, and what do you do with them?
So basically, we require the patient must give us consent what to do. So every year they have to tell us whether to continue storing them or to discard them. Some patients also elect to donate them to somebody else, which can be useful. So we have some patients who can't afford IVF. So some patients got limited finances. They come in here and someone else has donated embryos. They can do a very cheap frozen embryo transfer with a donated embryo, and allows them to have a baby. It's almost like adopting an embryo from birth, So those are the main options for embryos. And the patient has to give us permission to do one or the other,
So they may be destroyed legally?
Yes, as long as the patient gives us consent, yes, then they can. Okay.
And then just from my side, I'd like to know, what are the advantages of ovarian tissue thawing? Are you going to talk about, freezing? And
The main one is in prepubertal girls. So before puberty, that's your only option. Some clinics around the world have done quite well with ovarian tissue freezing, and they're doing it in cancer patients. The one advantage is you don't have to stimulate the eggs. There are certain times when ovarian stimulation might be too expensive in a certain country, but they can do a laparoscopy and harvest some ovarian tissue. But it's just that the overall, egg freezing has become such a widespread, easy technique now that it's kind of less invasive and easier to do. So this is a picture of the human oocyte. It's actually the largest cell in the body. You can see it with your eye if you look in a dish. It looks like a little pencil point, but it's that big that you can see it with your naked eye. It's about 0.1 millimeters. The sperm is the smallest cell in the body, interestingly. You can see the sperm inside that little glass pipette there in the picture, So the first thing we have to do with understanding eggs is how do they develop? So I'm going to go take you back to embryology again and just talk about when eggs are made. So eggs are made in fetal life in the woman. So primordial germ cells in the ovary during the early fetus, first developed by mitosis. So first you get a whole lot of cells are made by mitosis. about 7 million of them. And then at 7 months of fetal life, they go into the first stage of meiosis and they rest at that stage. So then you can't make any more, basically. So you end up with a fixed pool of eggs in about 7 months of fetal life. So these are called the primordial follicles. So the top, if you look at the top illustration, it's just showing what happens in fetal life, where you get these sort of stem cells and then they develop and you get the primordial follicles. Later on, the follicles will develop. So we start with a primordial follicle, then it becomes a primary follicle. Pre-antral means you can, it's getting more and more little granulosa cells around it. And then it starts getting fluid inside, which we call the antrum. And that's what you can see on ultrasound. So if you see an egg in the ovary on ultrasound, it means it's an antral follicle because you can see some fluid inside. And then the antral follicle, the antrum gets bigger and bigger until it ovulates. So the first thing we do when a patient comes to us, in our first consultation, is we basically doing a fertility assessment before we're doing egg freezing. So there's two things we want to know. We want to know the egg quality and the egg number. So the egg quality is basically related to the age of the woman, because that tells you the percentage of genetically normal embryos you're going to get. So if you're young, maybe 50% or 60% of your embryos are going to be normal genetically. If you're older than 40, then only maybe 20 or 30% will be normal. So the age is critical. Then the other thing is, how many eggs will they produce? Because it helps us a lot if somebody's going to produce 10 or 15 eggs compared to 1 or 2 eggs. So that's basically looking at the egg number or the ovarian reserve, but they're kind of different. So what about the ovarian reserve? How do we actually check this? So as I mentioned, we lose a certain number of eggs in the ovary, but we want to know how many are left. And the main two techniques we use is a measurement called AMH, a blood test, anti-Müllerian hormone. I'm going to talk quite a bit about that. And then the antral follicle count, which is on scan. So the AMH, the proper name is anti-Müllerian hormone. And the blood level can be checked easily at any path lab. So you just send them there, and there's two different units, nanograms per mole or picomoles per liter. And the one is, it's basically just a conversion thing. So the picomoles is like about 7 times the nanograms per mole. So if I'm just going to talk about nanograms per mole, because we're kind of familiar with that, but the normal range is about 1 to 3 nanograms per mole. So you can just send any of your patients, and you can see, are they in the normal range for egg numbers? Is their AMH around about 1 to 3? The PCO patients got lots of eggs, their AMH will often be above 5. And so AMH is just it's like a chemical, a member of the transforming growth factor beta group, TGF beta. But it's quite interesting because it's got a whole lot of roles in fetal life, does a whole lot of stuff during male and female fetal life. And then we use it later on for fertility to assess egg numbers. And it may do other stuff that we don't even understand yet. So we think that AMH actually affects the follicular recruitment in the adult. So there's some kind of interaction between AMH and how many follicles are recruited every time you stimulate a patient. And it's produced by the granulosa cells that surround the actual oocyte, the AMH. So it's interesting just quickly to talk about the AMH in the male fetus. So, because I used to get confused between AMH and, is it the same chemical that everyone's talking about in embryology? But it is actually. So an AMH is produced in the male fetus in the Sertoli cells, and the Leydig cells produce testosterone. So the male fetus actually starts at 10 weeks. The male starts producing AMH. And it's got all different names: Müllerian inhibitory substance, Müllerian inhibitory factor, Müllerian inhibris was the first name. This guy discovered it, Alfred Joost, in 1940 already. And it basically stopped the development of the female system, the upper vagina, cervix, uterus, and fallopian tubes. And then the Wolffian ducts, which formed the male system, were stimulated by testosterone. So the male, it has to make AMH to stop the female system and testosterone to develop the male system. So just to show that AMH is also relevant in males, but only during early fetal life. And AMH in the female fetus is interesting because the primordial follicles are only produced, like I said, at 7 months gestation, 32 weeks. So that's when the oocytes are actually made. But the primordial follicles don't have any much granulosa cells around them. There's just one little layer. So there's not enough of them to produce AMH. But then gradually they sort of form primary follicles, which got more granulosa cells, and then they start making AMH. So we can't actually detect primordial follicles in a fetus or in an adult. We don't know how many primordial follicles are there unless we do, there's ways histologically of trying to do it. But we actually measuring the AMH, which is measuring a certain follicles, primary follicles, pre-antral and antral follicles. So we're measuring the same as the little ones you see on ultrasound. And as I mentioned, the granulosa cells produce the AMH. So the AMH is also used as a marker, interestingly, for granulosa cell tumors of the ovary, because it's made by the same cells. So every month you get some follicles that grow and some that die off. So the follicles that die off, the treatic follicles, they don't make AMH. And interestingly, the large ovulatory follicles also don't make AMH. So there's only the follicles at a certain stage make it. So just to summarize an AMH in different fetal ages, it's first detectable at 36 weeks. Infant, even a baby's got a bit of AMH because they've got a few primary follicles. So there's about 1 nanogram per mil in a baby. Childhood, it's about 2 to 3 nanograms per mil. In puberty, it spikes very high, goes up to about 4. And then in the adult woman, it goes down to 1 to 3. So if your patient's got a low AMH less than 1, then they've got a problem with their ovarian reserve, and they may not stimulate very well during IVF. And if you've got PCOS, it will be high. So one interesting question is, how long does it take for a follicle to actually grow from the primordial one until the one that pops out, the ovulatory one? It actually takes a year from primordial follicle development to ovulatory follicle. So 10 months from the primordial follicle to the antral follicle, the one you can see on ultrasound, and that starts becoming sensitive to FSH from the pituitary to grow it. And then only in the last like 2 months or so, then you actually get sensitive to FSH and go into the final ovulatory follicle. So just to show you my picture again from before, I've put in a red block the ones that make AMH, which is the primary preantral and early antral follicle. So you're picking up AMH from certain follicles in a certain developmental stage in the ovary. So the other way we can check how many eggs are left in the ovary other than AMH is doing a scan. You can do an antral follicle count. So it's a transvaginal ultrasound. It's quite important because there are some measurements for transabdominal ultrasound as well, but the counts are different, and it's more difficult to do. So the Graafian follicle is just a word for all different follicles, okay? But the antral follicles, they've got like small, medium, and large. And then the big ones are the ovulatory follicles between 18 to 23. But basically, when you're doing an antral follicle count, and I've got a picture there of an ovary on scan at the top, those little follicles you're measuring, those things are under 10 millimeters. So that's what you're measuring when you're measuring antral follicle count. You shouldn't count the ones above 10 millimeters. And the normal antral follicle count is 10 to 20 per ovary. And sorry, in total, 10 to 20 follicles overall for both ovaries. If you have less than 5 in total, then you've got a very poor ovarian reserve, and you're going to really struggle with your IVF or egg freezing. So just remember, there's showing you a picture of the ovulation, the follicles as they develop. We know they're going on for many, many months before we see them. Then when we see them, we're seeing the ones with the little black dots in the middle, which is the fluid inside them on ultrasound. So just to mention PCOS, because people often ask about antral follicle count and PCOS. So PCOS, the old Rotterdam criteria is there: irregular periods, hyperandrogenism, and at least 12 antral follicles had to be visible, or ovary more than 10 mils or 10 cubic centimeters. If you take the length, the width, and the height, and you times it together, you should get 10. So the criteria for PCO is actually 10 antral follicles or 1 ovary more than 10. That was what the Rotterdam said. Then what happened was the ultrasounds got a bit better. So then people could see more antral follicles, and everyone started getting diagnosed with PCO. So then in 2018, they said, okay, hang on, wait, make it 20 instead of 12, because the machines are better. And then in 2023, they kept the 20 antral follicles to make a diagnosis. So you have to have, even in one ovary, if you see 20 antral follicles, you can diagnose PCO, or if the ovarian volume is more than 10 cubic centimeters. But in 2023, they added an AMH as another alternative as well. So if you've got a very high AMH, more than 5, you could use this as an alternative to your ultrasound as well. So that's just a little side note about PCO. And this is the algorithm you're supposed to follow with PCO. You first look for irregular cycles and clinical hyperandrogenism. If you can't find that, you do checks for biochemical hyperandrogenism. And if you've got, if one of those are positive, then you do your test for PCO on scan. So what about the pill? Does the pill affect the antral follicle count and AMH? Because a lot of people are on the pill these days. So the pill can definitely lower your AMH and antral follicle count, and other contraceptives like some of the progesterones, like IM progesterone, and so on. And there's one study here that I quoted in 2019. They looked at 68 women, and they had a drop of 53% of AMH, and the antral follicle count dropped by 46%, quite dramatic. And the American Reproductive Medicine Society says at least 20% reduction. So we have to remember that if we checking women who are on the pill to check their fertility. So if they've been on long-term pill use and that, we often still stop the pill for at least 2 months and recheck everything again. So we don't want to tell them their fertility is bad. It might just be a pill effect. Okay, so let's go on to egg freezing. So basically, this is freezing unfertilized eggs. And it started with cancer patients, but now many patients do it for sort of what they call planned oocyte cryopreservation is a proper word. And a lot of people talk about social egg freezing. You know, for patients often who's single or in a relationship, but they're not ready for treatment. So these are the type of groups that will come to us: cancer patients, some patients at risk of premature ovarian failure, like fragile X Turner's mosaic, or they're going to lose their ovaries from surgery, for example. You might want to freeze some eggs quickly. But 94% of all the patients who are doing it are basically age-related. And then egg donor programs sometimes freeze eggs. And there's a few weird and wonderful indications as well, like women in military who might die and they want to freeze their eggs before they go out to battle. Transgender patients is another group we're seeing a lot of. And some corporates are also facilitating. They're paying for their staff to go for egg freezing. So how is it done? We use, they're frozen in liquid nitrogen. We use a method called cryotech. They're frozen at 196 degrees in liquid nitrogen, and you can keep them for many years. And they're all different tanks that you can use, simple tanks, and there's mechanical pump tanks and all these things. Labs have to be very careful that the tank doesn't fail and that there's sensors to warn about these things. And obviously identification of samples is important. And there are various techniques for that as well. So there's a picture of a little cryotech kit, and that magnified thing, you can see that little loop with 2 oocytes inside there that are going to get frozen. So this is what a liquid nitrogen storage looks like. We have about, I think about 35 tanks in our lab with embryos going back to the 1990s. So you end up with many thousands of eggs and embryos stored in labs. And just managing the liquid nitrogen systems and keeping all the admin up is quite a big job. So how do you do the egg freezing? So you first inject some gonadotrophins to get multifollicular growth. You have to give some medicine to stop them ovulating. You can either use oral progesterone, which is easy, just like Dufaston or Provera, and you can do an injectable GnRH antagonist like Cetrotide, Cetrorelix. So you can use either method to stop the patient ovulating, and then you do a trigger injection to get the eggs out. So we used to use HCG, but that's got a risk of hyperstimulation. So if there's more than about 10 follicles, we'd rather use the new GnRH agonist to trigger, then they don't get hyperstimulation. So that's basically the medical treatment. And then you will monitor them, you know, so they'll start on day 3 of their period. You can do a random start. If you've got a cancer patient and you haven't got time, you can just start stimulating them any old time, because you're not going to put the embryo back in their uterus. So it doesn't matter if their uterine periods are out of sync with what you're doing. And you can continue if they're on a progesterone contraceptive. It doesn't really affect it. Like if they've got a Mirena in or they're on depot, it doesn't matter. You can still do the egg extraction. So the patients self-inject, and then you scan them like day 8, 10, 12. You work out when the follicles are ready, and then you do a retrieval under sedation around about day 14. They just have to take 1 day off work for that. The other days it's just a quick visit in and out for a scan. So it's actually very easy, the treatment. It's very patient-friendly. Patients inject themselves. They pop in for a few scans. And often the patients tell us afterwards, is that all it is, you know? So it is much easier than the old days when people had to have, you know, intramuscular injections and all that. So just some stats quickly at success rates. I won't go too much into all this because everybody's tired and it's late in the day. But just to give you an idea, from IVI Valencia, they looked at quite a few, they've been many thousand patients. And what's interesting was about 10% return to use the eggs. The other ones just froze them and didn't come back, which is interesting. But they also were recovering about 85% of all the eggs when they thawed them in the future. And how many eggs do you need? This is an interesting question. So their stats showed if you had 10 eggs, if you were young, 35, you'd have about a 56% chance of getting a live birth or a baby. If you were older than 35, like 37, 38, it went down to a 30%. So the number of eggs, if you have 10, you've got like a reasonable shot. If it goes up and you get more eggs, like 15, then in the young patients goes up to 85% live birth rate. So a lot of guidelines have changed now to try and get the patients to actually produce more eggs, like up to 15. So if they only produce 6 or 7 or something on the first go, they can just repeat the thing after a few months and get a bit more eggs in the bank. And they've got definitely more chance of getting a baby at the end of the day. So here on the internet, there's even egg calculators now. So you can go on the internet. There's tons of these websites. I just pulled up one of them, Omni Calculator, from a website. But so I plugged in some things just to show you, like if you're 35 and you have 15 eggs, then you've got 82% chance of getting a baby. If you're 37, you need 25%, 25 eggs, a lot more eggs to get the same chance. And if you're 40 and you get 40 eggs, then you only got 76%. So as you get older, you need more and more and more eggs to achieve your live birth. And it's important for women to understand this. So if they only get 2 or 3 eggs, it may not give them, sufficient chances in the future. So ovarian tissue transplant.
I just ask you, what in South Africa, how does it look? I mean, you're freezing a lot of those eggs. What percentage of patients actually come back for those eggs?
Yeah, I think we don't have stats on that, to be honest. So we know we're doing about 200 retrievals per year. We are definitely getting patients coming back, but I don't think we have stats exactly on what the return rate is. I think we still have to look at that. I think Valencia was the first clinic in the world that started doing egg freezing. So they were just a bit ahead of everyone, and they've got quite good stats for the returns. They're starting to see from the original freezing how many people have come back, but it takes a bit of time. So now for my career, I started freezing 10 years ago. So now I've started getting those patients coming back, and we're seeing, how it all goes, which is interesting. Yeah.
Are those eggs, they have to have they finish the whole process with your lab, or is it something that people can transport, say they move, or they
no, they can certainly transport them. Yeah. So it's quite easy to transport them in nitrogen. And in fact, we send them all around the world. So people can move them if they move or something like that. Yeah.
Okay.
Ovarian tissue transplant, just to talk about it quickly, I'm just mentioned one interesting case we did. This was a long time ago, 2009. I was involved in this case. It was the first live birth in Africa. We took there was a woman who had no medical aid, so she couldn't pay for egg freezing. So we took her to theater and did a laparoscopy. We took out one ovary and cut up the cortex of the ovary and froze it. She had lymphoma. And then she came back in 2013, 4 years later. And then we basically reimplanted those little strips back into her pelvis. And then she had a spontaneous live birth afterwards. These are the little bits of ovary after we cut the ovary up in the lab. And then we thawed them out. This is after they thawed, come out of the nitrogen. And this is me and Suleiman stitching them together to make a little blanket to put on the ovary. And then there's a little blanket there. And then we put it through a laparoscopic port, and then we just sutured it onto the ovary. You can see it being sutured onto the ovary, the little thing. That's actually a menopausal ovary. So we just made a little raw area on the ovary, and then we sort of stitched our little blanket on there. And then that was a patient afterwards, a simple laparoscopy. She was fine. And then there was the baby. Yeah.
So this was very well publicized in the media, wasn't it? Well, I remember.
It was well publicized. What hasn't been publicized out of interest is 2 years ago she had another set of spontaneous twins. So she's 3 babies from that original transplant. Yeah. So it's quite an interesting story. Yeah. And then just one last interesting thing to end with is, as I mentioned, our understanding is that eggs are made in fetal life, and it's stuck at that point. We can't make any more eggs. So if the woman's eggs run out, we're stuck. But is it true? Is it true we can't make any more eggs from stem cells? So there's a lot of work going on, and this is a big research unit in Valencia. So in animals, they've worked out now how to stimulate stem cells in the ovary. So they've actually make the animal, the little rat, they make it menopausal. They radiate the thing. And then they've stimulated stem cells to go back into the ovary in the animal, and it actually starts producing eggs again. So they can make basically a menopausal rat start producing eggs again and actually have babies. And there's a little picture of the little rat babies at the top there. So it's like really fascinating. And now the question is, can we do this in women as well? This is a pilot project that was started in 2018, and there's still a lot of work in Valencia where they're basically using various growth factors and putting in bone marrow stem or stimulating bone marrow stem cells, because they float around your body and some of them seem to activate in the ovary. And people are trying to work out whether they can actually get the ovary to produce eggs again. And it seems like there is actually, some in the future, this is going to be possible, but it's still very early days. We're waiting for the research, but it's very exciting stuff. So just to conclude, women need to be aware that there's a serious decline in natural fertility after the age of 35. So they should really, if they're going to have children after that, they should really think about preserving their fertility. And, techniques like IVF and egg donation assists many patients to have children every year. But we can sort of retrieve or achieve reproductive immortality, preserving the genetic quality of human eggs with egg freezing and ovarian tissue freezing. And in the future, stem cells might also be used, but we're not there yet. So thank you so much for your attention, and I appreciate the opportunity to speak tonight. Thank you.
Paul, it's been wonderful. There's one or two questions. First question is this. What is the cutoff age above which you would not consider women for assisted reproductive technology and techniques because of the higher risk of infertility and the higher risk of genetic abnormalities? Where do you put that age?
Okay, so the last age that we really practically get pregnancies at all is age 44 using people's own eggs. So if a patient's 45 or older, they're all going to get recommended to do egg donation. But even the woman at 44 is a handful of people that are going to achieve this. So just to put things in perspective, if you're 35 years old and you put an embryo inside, you'll have about a 45% chance of getting pregnant each time. By the time you're 40, it's only 25%. And over 40, it basically halves every year. So if you do IVF at 40, you've got 25%. If you do it at 41, you're dropping down to about 15%. 42 is 10%. 43 is only about 5-6%. 44 is a 1 or 2%, and 45 is essentially zero. So
wow, it's a bit of a waste. It's a bit of a waste of time to go much above 42.
Yeah, 43, 44, you're going to have to do quite a lot of IVF and you're going to have to get quite a lot of eggs. So we still get quite a few pregnancies, 42, 43, 44 is really dismal. And 45, the patient's mostly just wasting their money. At 45 onwards, patients should rather be encouraged to use egg donation. Obviously, if they froze eggs before, they can still use them. They would work like an egg donor as well. So if you froze eggs when you were 32, then it doesn't matter if you're 40, 42 and you come back. But we do tell patients, with egg freezing, nothing is 100%. So the set for frozen eggs might not work in the future. So you shouldn't just delay your fertility, too long, because if the frozen egg batch doesn't work, we're still going to have to go and retrieve eggs from them again.
And then Paul, so say someone's frozen their eggs at 35. I mean, when's the cutoff in terms of using those eggs? I mean, do you have something like an age of 50 or 55, or is there some rule?
So for egg similar to egg donation, there it's more just the maternal risk, I think, and it's very controversial, okay, in terms of when should you stop, because some people say, doctors are being too paternalistic and why must we make all the rules? But generally, all the most reproductive organizations will say around about the time of natural menopause probably is the time to stop. And there is a bit of justification in this because women's medical risks start increasing. So over the age of 51, if you're pregnant, you definitely have more medical risks, preeclampsia, diabetes, even heart disease in pregnancy, like coronary artery disease. And we've had patients that have, we know, patients that have had egg donation over the age of 50 and have died in pregnancy. So I think it's not something that should be done without a lot of caution. So we generally stop patients carrying babies after the age of 51. And then we have a special ethics board that will look at a few patients between 51 and 54 in exceptional circumstances where the patient then has to go through a whole battery of tests, to a physician and a cardiologist for stress ECG and mammograms and psychologist. And we have to check the obstetrician's also okay with the patient. So they go through a whole lot of hoops to decide whether it's okay. And then we also would probably only do it if the patient had already been doing treatment maybe and they've got some frozen embryos left and they've just gone over the age of 51 and it seems reasonable to carry on. But I think starting patients over the age of 51, it is quite controversial. And people have different views, but I think one should be a little cautious, yeah.
Paul, another question over here. you the president of the African Federation of Fertility Societies. A person asked over here about the cost of IVF. Many years ago, there was a talk on a $5 IVF. Is there any way of bringing down the cost of IVF? You did mention at the very beginning that you can donate embryos and then it's much cheaper. But if you don't do that, how can it be that a person can have a slightly less expensive program, particularly in our African context?
Well, I think the one thing that, if you go to Europe and in America, the governments fund IVF a lot, you know, so many countries, the governments are understanding that IVF is an important thing. I mean, 15 to 20% of the whole population has infertility. It's a huge number of people that are suffering with a lot of psychological distress. So the one aspect is to try and get some additional funding for patients from governments, from medical aid. Discovery started paying for IVF on their top plan in 2021. So if you're on the classic comprehensive plan and Discovery, then they pay for 2 cycles, or 75% at least of 2 cycles of IVF. So Discovery, it took a long time, it took like 15 years of us talking to them, but eventually they agreed, and that was great, you know. So it started, but it's a step forward in funders realizing this is an expensive therapy, but it's quite critical for that patient. You know, it affects their quality of life if they never have children. And, you know, one can say, you know, other things, for example, if someone's got prolapse, no one will say you must just live with that. It's uncomfortable, bad luck, you know. But I mean, fertility, people are happy to say, you know, you must just be miserable for the rest of your life and not give anything, you know. So, you know, I think people are becoming more aware. There's more pressure on governments and medical aids. In terms of doing low-cost IVF, William Ombelet is a doctor from Belgium who developed a thing called the Walking Egg Program. That was a very simplified little mobile incubator in like a container that drives around. And inside there, they had a very simplified lab thing. And he showed it could work. But the thing is, it was unfortunately tested in Belgium, and it was with access to other fancy labs and embryologists. So fancy embryologists could make these low systems work, but we want to know, will those easy systems work without that scientific backup in the background? And there's a guy in Pretoria called Gerard Boshoff who's doing his PhD in Pretoria using the Walking Egg Container Program, trying to see if they can help some patients. So I think there are strategies to doing it. But I think the other aspect is trying to get people to be aware, you know, and to try and assist patients a bit.
We spoke last week to Ichnu. What psychological support do you offer your patients because of the stress that you mentioned?
Yeah, I think it's very important. You know, it's interesting in some places in the world, like in Australia, even where they fund IVF. So there the clinic is saying, no problem, we'll pay your IVF. A lot of patients drop out because of the emotional burden. So if they get a negative result, nobody sees them afterwards. They feel miserable and they just stop treatment. And that's critical for us because we know the more embryos we put in the patient, the more likely we're going to get a baby. So for a patient to stop after one treatment, it's actually really bad because they could have got pregnant with a couple more treatments maybe. So the psychological thing can stop a patient completing their treatment. So they're actually almost shooting themselves in the foot now because they haven't given themselves enough chance to actually get pregnant. So aside from any sort of just being nice to the patient, it actually affects the success rate if you don't look after the patients nicely. So you have to have systems to look after patients. And we have psychologists that are linked to our clinic. And we provide the details to all the patients, and a lot of them do access a psychologist, and you need psychologists that are interested in fertility stuff so they know what the patient's talking about. You know, so I think it is really important to do that, and also for the clinic to follow up patients who've got negative results. Some clinics I hear about, they don't bother, you know, following up the patient afterwards and things like that, and that's really bad. So you know, often when a patient's got a negative result, we'll just tell them it's negative, but it's very important to tell them and come and see me next week to discuss the next steps, even if they don't do anything, because they're miserable when it happens, but they need that extra support to come forward, you know. And our IVF nurses are great, I must say. They like the forefront with the patients, and they often keep the patients going, yeah.
Paul, sorry, excuse my throat infection. On the subject of, on the subject of money, do you have lots of overseas patients coming through for IVF, given the extortionate cost overseas of IVF programs?
Yes, we do. You know, it's quite interesting. We have a certain proportion of, I'd say probably like up to 30% of the patients that access clinics, and not only ours, probably most clinics in South Africa are coming from elsewhere. And we have different groups. We've got now a lot of patients coming from the African continent, actually. So, for example, countries like Angola and Namibia, Zimbabwe, the local ones close to us, a lot of them, the IVF services are not very well established. So they just come for regular IVF because they can't access it in their own country. So that's quite a big group. And then we have patients that are looking for egg donors. Typically, we have quite a lot from Australia where the law is different and they need a known egg donor. So they can't often find a known egg donor. So they start looking around the world, where can they travel? And they sort of gel, I guess, with South Africa, the Australian. So a lot of them will come to South Africa to do egg donation treatment, and not really so much regular IVF. And then you'll get a few patients who are coming purely for cost from the UK and States and the United States and places like that. But I find a lot of the patients who come to us, they ex-South African, or they've got some friend, you know, something like that, who referred them, you know, somebody, just word of mouth, you know, that kind of thing.
There's another question here, Paul. Is there from anonymous attendee? Is there any are there any criteria concerning BMI for any of these techniques?
We've mentioned, where's the BMI input?
Yeah, so the BMI does affect your success in IVF. So if you've got a very low BMI or a very high BMI, then you're going to have problems with stimulation of your eggs and the quality of the eggs and so on. So BMI is quite relevant. It doesn't affect all different techniques. I mean, in egg donation, they're probably not so relevant in that, but obviously it could affect the pregnancy later as well. So if you get the patient pregnant now, they can get gestational diabetes and everything as well. But, you know, if you've got a very high BMI, it definitely can, like especially in the PCO patients, it can reduce the success rate for the patients. And obviously it can make some things difficult, like the anesthetic and so on. So we try our best to get the patients to pay attention to their BMI and go on diet and go to gym and all these things. But we also realize that it's a lot of the time, it's very difficult to get them to lose weight. And the problem is, if you tell the patient to try and go to gym and eat well and all that for 2 or 3 years, by the time they come back, they're too old now. The eggs have got worse. So you have to be careful not to delay patients too much. So I think you must try, but within a reasonable time frame. You know, but there are definitely risks with the fertility process and with their pregnancy with high BMI.
Paul, on a similar vein, what about HIV status? Does that in any way affect your outcome?
So with HIV, things have changed dramatically, because when I started, you know, there were all techniques in fertility to reduce the risk of HIV being transmitted from one partner to another and to the baby. But that's changed now, because we know if you take HIV antiretroviral medicine and your viral load is undetectable, then basically you can't transmit to your partner or to the baby. So the techniques is basically now, it's almost like medical. We send them to an HIV specialist. They treat the patient until their viral load is undetectable, you know, for like 3 to 6 months. And we know, like, okay, the patients can't transmit now. And then they can just do regular IVF. We don't have to take any special precautions or anything. And for the baby, it's safe as well. So the focus has been more on pre-treatment and getting them to have an undetectable viral load than actually doing like ICSI or washed IUI and all that like we used to do.
Paul, that's fantastic.
Excellent.
I'm going to ask Steve to thank you now. It's been a wonderful talk,
Yes, thank
Steve.
you. Yes, thanks, Paul, as always. I mean, you've really led the way in Cape Town and also in Africa in a lot of these techniques, and we really appreciate it. I mean, we both had patients managed by you, and I mean, not only is Paul very knowledgeable, but he's very compassionate, a very good doctor. So it's great to hear just an update on this. Patients do ask, even in a practice like mine, they do ask questions around these things, and you know, it's nice to know exactly what to say to them. So thanks, it was a great and very informative talk. Thanks, and really appreciated that. So
Thank you,
yeah.
Paul.
Anything else you want to say, Pete?
Yes, I'd like to finally thank Merck, Michelle, for a wonderful sponsorship and the largesse they have around education of infertility and fertility matters in Africa. And then it would be quite wrong for me not to mention that in exactly 1 year's time, Paul, what are we going to be doing, Paul, in exactly 1 year's time in Cape Town?
We've got the Pan-African, are you talking about the endometriosis conference or something else?
No, I'm talking about FIGO. I'm hoping you're going to be able to present, maybe even do a workshop at FIGO, because I mean, what
Oh,
you've
figure, yeah,
done is
figure. Yeah.
figure. What
Mm.
you've done is wonderful, and I think it should achieve lots of recognition, because these are questions that the general gynecologist ONG coming from all over the world, and especially Africa, would be very interested to learn about. And if you wish to do a workshop, I'm sure it'll be highly well received and an important contribution to the wealth of knowledge.
No, thank you. Yeah, we'd be honored if our AFFS organization can have any sessions or whatever. We'll, bring fantastic speakers from all around Africa to participate. Yeah.
But without sessions, I mean, just if you wanted to submit a workshop proposal, you've got to do it before the 1st of November. It would be wonderful, because these are the topics that can be workshopped with question and answers in a classroom. So,
Sure.
Steve?
Good, well, thanks so much. And I mean, we are looking forward to FIGA. It's happening right at the conference center next door in exactly a year's time. So we look
Exactly.
forward to that. And he's always putting pressure on me to do that. So we've got till the end of October to do that, Paul. So
Okay, great.
we
No,
all know
thank
about
you
FIGA
so
now.
much.
Thanks
so much.
Thanks. I'll
Well, thanks
stop
again.
talking about you.
No, of course. We'll just keep reminding us. We can't hear enough about it.
And
So-
finally, then next week, same time, same place, Britta Dedicant, latest screening options for breast disease.
Thanks so much.
And it'd be quite wrong of me not to thank Steve for the use of your mini bar,
It's a pleasure.
as always.
Good.
Safe
Excellent.
home, Paul, and
Thank
all
you
the
very
very
much.
best. And thanks to our
Thanks very
sponsors.
much. Thank you very much. Bye-bye.
Thank